Thank you. I'm so glad and honored to be here to share my experience with you. And I'm a doctor from our pancreas center. And so I'm very sorry I changed the title to the role of endoscopy in cholangiopancreatic diseases. This is three parts of my presentation. The first will be the endoscopy for cholangiopancreatic diseases, and then we discuss the diagnostic and therapeutic applications. Then first, let's see what kind of endoscopy can be used for cholangiopancreatic diseases. It should be include EUS, IDUS, ERCP, and POPS or POCS. And first, let's see the EUS. The EUS, we now know it has an advantage of high detection rate, not high solution, but high detection rate and low cost, less trauma than laparotomy. And it can be used to in the tumor staging, in the chronic pancreatitis, pancreatic cystic tumors, and PNET. And the important thing is the negative predictive value was nearly 100%. What's that mean? If the US procedure performed by a skilled doctor, it can almost, if the result is negative, it can be 100% true, right. And mostly the US can offer the FNA, offer the pathology results. And intraductal ultrasonography is a technique based ERCP. And for cholangiocarcinoma diagnosis, it's better than US on accuracy, sensibility, and T stage. And ERCP is, can obtain a diagnosis for biliary and pancreatic diseases. And it also can offer pathologic diagnosis, and also it can be in therapy application, like the biliary and pancreatic drainage. The last one would be the POPS or POCS. This is a very important invention for the BD and PD duct diseases. It obtained visualization and histological diagnosis of cholangiopancreatic duct lesions, and also it can be used at therapeutic application. The POPS it can be used for identifying pancreatic duct stenosis when the US FNA does not provide definitive results. And it can some branch technique like confocal endoscopy and to elevate the accuracy. And next, we will talk about the diagnostic applications. Mainly is US and the POPS. The US-based diagnostic technologies would be tissue harmonic imaging, enhanced US elastography, confocal laser endomicroscopy, and fine needle aspiration. The contrast-enhanced ultrasound is widely used to identify the benign and malignant lesions of the pancreas and other organs. And it has very high sensitivity and specificity. The other is elastography. It also has a very high sensitivity, but middle specificity. The most value of it is the biggest value is it can expand in our fine needle aspiration range to improve accuracy. Talk about fine needle aspiration. We know that it has very high sensitivity and very high specificity, but it's not the specificity is not 100%. Why? Because due to the presence of chronic pancreatitis, there still is a false positive rate of about 1%. This is the image of the pancreatic cancer of EUS. It showed hypoechonic lesion, obscure boundary and crumpled irregular shape, and local cystic change, vascular invasion. All this information is very important to our decision making. For pancreatic tumors less than 3 centimeter in diameter, that means small tumor. The sensitivity of EUS is higher than the traditional image. The EUS scan should be performed for all patients with jaundice or biliary or pancreatic duct dilation that suggests negative on traditional image. For chronic pancreatitis, even if imaging shows no malignant evidence, a follow-up EUS scan should be performed. The EUS can obtain the TNM staging. The EUS staging in the T staging and vascular invasion is very high. Also, as well as the lymph node metastasis, the total accuracy in judging surgical resectability in pancreatic cancer is 80%. And there's a lot of cystic tumors in pancreas. The main type is SCN, MCN, SPT, and IPMN. In the all the kinds, the main identification is to define it whether it's mucus or serous, and applications including just talked in the last slide, and about CEUS, confocal laser endoscopy, transneedle endoscopy, that should be cytoscopy. And the last one would be cyst flood analysis. In the cyst tumors, there's challenging to acquire the sample, the solid sample is challenging for the operator. And we know some procedures can elevate the tissue acquire. And till now, the most hopeful way is to choose the needle biopsy. It has a very high technical success rate. The combined diagnosis rate on cyst was better than traditional FNA and has a middle complication rate. The chronic pancreatitis can be diagnosed by EUS. It has some image feature with like pancreatic duct dilation and distortion, pancreatic duct wall calcification and stone. And also you can see multiple calcifications on pancreas, and also the other characters about complications of CP. But sometimes you see the mass chronic pancreatitis. It should be diagnosis between the CP and pancreatic cancer. You can use the EUS view the pancreas and pancreatic duct to see the character, whether there's a feature of CP, and also you can use the fine needle aspiration to get pathology diagnosed. So there's many guidelines involved EUS in the diagnosis of the CP. And also there's some kind of cholangiopancreatic duct disease, there's ways to diagnose, but I think the most available is the POPS or POCS. The POPS invention, the concept of POPS was first proposed by Hawaii in 1976, but with the advantage, with the technique advance, it makes more controller and more useful. But till 2007, the spyglass invention, it can be, we first time go to get the clarity image in the PD or BD. Okay, POPS or POCS, not only a tool of diagnose, but also a useful tool for treatment. It can obtain the visualization and histological diagnosis of cholangiopancreatic duct lesions. Also, it can see whether it's benign or malignant cholangiopancreatic duct stenosis. This is a case our have do about 2 years ago. This is a up GI bleeding after the pancreatic duodenectomy for 5 months. The normal endoscopy cannot see whether there's the bleeding reason, but we have seen the blood gushed out from the pancreatic enterostomy. And so we do the POPS in the pancreas. Then we see spotted blood seepage remained even at the duct wall, and even after washing, they still remain keeping. So this patient got a diagnosis of the bleeding in the PD. Was discharged after conservative treatment. This is also another video of the POPS application in IPMN. You can see a lot of mucus in the PD, and also you can see some nodules on the wall, and also egg-like nodules or finger-like nodules, transparent nodes on the wall. There's a time limit, so I will skip it, sorry. The last part, let's talk about the therapeutic applications. The main for treatment is the US interventional therapy, the ERCP, and the POPS or POCS. First, let's talk about US therapeutic application. The tumor fine needle injection, FNI. It can be used at pancreatic cancer, PNET, pancreatic cystic tumors, or liver metastasis. There's several kinds of agent you can inject into the tumor, but till now, the only useful and with data analysis is ethanol. Another treatment is interstitial brachytherapy, which we had to do for about near 10 years. It mostly is radioactive seeds implantation. Use the US FNA. Use the US. The feasibility and safety have been proved in the article or our experience. And currently, it's short of its lack the RCT study, and more studies are needed. We also can implant some drug-carrying particles into the pancreas, and for either the solid tumor or the cystic tumor, we can do the ablation. The physical the ablation is with two kinds, physical and chemical. The physical ablation, including the Moore ablation, radiofrequency ablation, or irreversible electroporation. Can be used in the FNA. But the most important is chemical ablation. It can be used at solid like PNET or cystic tumors with ethanol. There also has some persons have reported photodynamic therapy with EUS guided. And the celiac plexus neurolysis was another important use application in the pancreatic cancer who's unresectable. And labeling is another use this year's had appeared. First is US guided tattoo. The second is US marker planting for SBRT location. And those with marker implants could obtain lower radiation doses and durations. So it's helpful. And another application is US guided drainage of pseudocysts. We can use US guided drainage to treat the pseudocysts without surgery. This is our case. Use double pigtail plastic stent, and you can use the mantle stent to do the drainage. And also, if you use the lamps, the mantle stent, we can do the pancreatic debridement. This is our case of acute serous pancreatitis debridement. Also, because the time, I have to skip it. Sorry. This is all the pubs or necrosis we have cleaned out. The US drainage technique, including the USBD, USGD, and USPD. And in these years, another hopeful technique of US guided drainage will be the gastroenterostomy. It's suitable for the persons, especially old patients, who cannot offer the surgeon but need the bypass. They mentioned about the ERCP therapeutic application is biliary and pancreatic duct drainage, localization and protection of biliary and pancreatic duct, treatment of post-operative biliary or pancreatic leakage. About the leakage, there's controversial studies still to now. And we think the ERCP can indicate and protect the PD before the operation, before the pancreatic operation. And the last one would be the POPS or POCS therapeutic application. The main is lithotripsy treatment of PD or BD stones, especially hard stones, and radiofrequency therapy for PD or BD lesions. This is our video for the PD stones. Okay, allow me summary. As a minimal invasive treatment, endoscopy plays an important role in the diagnosis and treatment of pancreas diseases. The role of endoscopy in the perioperative period of pancreas will be further expanded with the advancement of new endoscopic techniques. Thank you.
Thank you, Professor Xiaobin, for this nice presentation. Now we will move to next speaker, Professor Wang. Will talk about upper GI neoplasia and surgical interventions. Any questions? Any questions? Questions after we finish the whole, okay. The discussion after the sessions.
And I'm a surgeon from the Gastric Cancer Center of the first affiliated hospital of Nanjing Medical University. And it is my honor to be here to present a video for you. I know gastric cancer is not very common in your country, but it is a very common disease in China. Yeah. And today I will show you a video about the total laparoscopic total gastrectomy with Roxanne anastomosis by using the overlap method. Yeah, here is a patient's information. It's a thin female. And the patient suffered from the upper abdominal pain and discomfort for 1 year. And there is no special in past history. And in our hospital, the EGD shows the 1 to 4 layers of the lesion on the posterior wall of the great curvature of the stomach thickened. And the CT scan also shows the similar results. Yeah, the tumor located in the great curvature. And the C stage is T3N0M0. And based on the results of the examination and according to the treatment guideline, we decided to perform the total gastrectomy plus T2 and plus number 10 lymph nodes dissection. At first, we performed the exploration, and there is no distant metastasis. And we suspend the left liver lobe at first. Then we dissect the gastrocolic ligament. And we try to dissect the right gastroepopyloic vessels. And during the dissection, we should be careful not to damage the ASPDV. Yeah. Then we dissect the vein and continue to isolate the artery. Then we dissect the artery and separate the GDA and the common hepatic artery. Then we try to dissect the tissues just around the superior pyloric area. Because after doing this, it is easy to find out the right gastric vessels. Then we cut it and transect the duodenum. Then we use a thread to make a punch for the reinforcement of the duodenal stump. It is easy with the cooperation of the operator and the assistant to prevent the leakage. Then the assistant just lift up the right gastric vessels, and the operator try to dissect the number 11P lymph nodes. And during the dissection, we should try to be careful not to damage the spleen artery and the vein. Then after doing this, it is easy for us to find out the right gastric vein. We just dissect it and continue to dissect the number 7 and the number 9 lymph nodes for the isolation of the left gastric artery. Then we try to dissect the tissues just around the portal vein to dissect the number 12A lymph nodes. Yeah, then we try to dissect the left gastroepopulatic vessels. And when we're doing this, we should just preserve the ISV. Yeah, the ISV. Then we separate the tissues just along the vessels of the helium of the spleen to try to dissect the number 11D and number 10 lymph nodes. We just, yeah, we're now dissect the number 11D lymph nodes. During the dissection, we should be very careful because it is easy for us to damage the vessels. Yeah, this is the short gastric vessels. This is the number 10 lymph nodes. Yeah, this is the last short gastric vessel. And now we finished the lymph node dissection. Then we isolate the esophagus and use a linear stapler to transect the esophagus. And we use a thread to mark the small intestine. Then we perform the extracorporeal small bone side-to-side anastomosis and use a barbed thread to close the comma incision. We make a small incision of the esophageal stump. And a linear stabilizer was used to perform the EG storming by using the overlap method. A bubbled thread was used to close the common incision. And we use another thread to reinforcement. We use another bubbled thread to close the Peterson's and mesenteric defects to prevent the internal hernia. At last, the drainage tube was placed. Yeah, this is the surgery information. And this is post-operative information. Finally, we dissect 63 lymph nodes, and the P stage is T3N1M0. Yeah, thank you.
Thank you so much, Dr. Wang, for the nice case. And I think we will postpone the questions till the end of the session because we are very short of time. So I have the honor of presenting Professor Fen Chuning. He's my professor, and he is a director, former director of the digestive endoscopy department. He will be presenting about the cooperative approach for management of upper GI submucosal tumors, the endoscopic laparoscopic techniques.
Hello, everybody. Good afternoon. I am second times agent. I am very glad. Very glad. I'm. I'm come from Nanjing Medical University, affiliated the first affiliated hospital, Jiangsu Provincial Hospital. No, 不是这个，完全。No. 错，没，没考上去，考错了。Today my topic is solid reconstruction application is esophagus submucous tumor. 哎，电脑用电脑讲。 My topic is application 3D the construction the self-assessment and treatment stage of endoscopy the surgeon the esophageal submucous tumor. Elevated lesion origin from layer below the esophagus is episurface muscular submucous propria. It's contained about 1% of the esophageal tumor. More than 19% are benign. Most of the lymphoma, more than 2 in 3. Location is the main middle and the lower segment of the esophagus, about more than 19%. Most of round over, I feel the irregular and the honest job. Other patients type of germ tumor, granulous cell tumor, hemigonal system. This is the ASG guideline for esophageal small volume symptom in the USCT examination include the malignant esophageal SMAT. Regular follow-up can be selected. Surgeon resection is recommended for patients with a symptomatic short time the prognosis includes involved. Suspected pleural malignant transformation. Chinese guideline 2080. Guideline the resection, the injection, the surgeon section perform the essential symptom insights in suspicion pleural malignant. Endoscopy resection the sector patient was suspected by operation examination pathology considered benign, but it cannot follow up the regular the strong weaning under the endoscopy the treatment because the endoscopy the advantage. The resection the method traditional the thoracoscope thoracic the esophageal tumor resection. Endoscopy resection the ESE store EFR. Yes, endoscopy combined the thoracoscope technology endoscopy localization existed the thoracic surgeon. Thoracoscope existed the endoscopy. Now is the endoscopy submucous tumor the dissection store combined with the thoracoscope technology. Which method to choose size, shape, location, the lesion, pathology, time, technology level, instituted complication of endoscopy bleeding, perforation, and gastro-associated complication, mucus injury, the fistula injury of adjacent tissues in the organs. Complication endoscopy the less factors the patient age, tumor, size, location, level, the adjacent tissues organ, the patient under the disease. Operative factor is the technology improved perception esophageal anatomy. Emphasis is the planning on how to effectively prevent complication based on the anatomic characteristic. This is the anatomy. Esophagus is 3 segment. Upper segment is the is the middle is the esophagus segment is very dangerous, very dangerous. Bec- Đúng rồi. Đúng rồi. Oh, yes, surgeon. This is the left view, a left line and a right view. Yes. This is the esophagus vein line inferior esophagus. This is the left view is the head article arch descending artery. Head arch. This is the endoscopy is the heart artery article arches. Esophagus vein is right. Descending artery is this is the descending esophageal submucosa is elevated due to the vascular compression. This is the esophageal elevation, the vascular compression. Our case was reported in the gastroenterology first in water. Second dissection is the aneurysm. This is the bronchial artery, the rest you bronchial expansion, internal pressure of the esophagus. This is the agglomeratus immense. Main inspection we measured is the endoscopy, the anchors, US and the CT. This is the CT, the lesion is about the 3.5 in length. Is the earliest we are used the store. Thoracic surgeon introduce patient. Thoracic surgeon is the fistula and the structure. Difficult dissection the operation the 5 horse. This is actually long diameter of the tumor was 8 centimeter. This is the CT is the size about 3 pointers and 7 centimeter, where compress the changes of the light under the. This is the thoracic sanctuary endoscopy tunnel dissection. This is the tumor is the here is the lungs tissues. Next is the patient is the patient. Mostly the tumor is the dissection. It's difficult to continue the separation. This is the thoracic way the Thoracoscope puncture the endoscope toner insinuate icternum gloss emitternization memory is termed and the tumor dissection complete dissection sexual muscle laser about 80 and 3 centimeter. Endoscopy USCT. Tumor is relative the adjacent anatomical structure cannot be the assisted better. The diameter with 4. Sorry, the reconstruction. Tumor yellows very, very clip, very, very the contributed over the tumor resistance, convenient communication with the patient about surgeon risk, surgical protect and set section, and the plan for complications. This is case 1. Tumor the lower esophagus with compressions. This is the CT. This is the paranormal pleasures. Case 2, the middle is the esophagus SMT. About some mucus 2 and 2 the size centimeter. This is US CT. This is the 3D the reconstruction. This is the tumor. Here the nearby the descending arch. The endoscopic section in operating room was recommended. Case 2 is the medial esophagus SMT. Case 3 giant sister adjacent the palate calium descended artery. This is the endoscopy, the US CT. This is the 3D reconstruction. This is the yellow. Is the biggest is the sister. Pathology shows esophageal bronchus cyst. This is the esophagus is the cyst is the pericardium and the thoracic separation. Muscle such as after dissection. Endoscopy the tumor is tonal. The store is the clipper is open. Case 4, man in 57 years, CT esophagus 4.7 and the 3 centimeter size. Origin US origin from some mucus. Concerning the cyst. This is the endoscopy. This is the CD, 3D. The cyst is the upper. Fibrin between tumor and the subclavian artery. Endoscopy section plain store, yes, dissection is is dissection pattern, clipper closed open tunnel. Pathology shows the esophageal bronchial system. Case 5, middle is SMT. SMT. This is the tumor is nearby the artery. Endoscopy combined the store with the oscilloscope. This is the tunnel, open tunnel. No divider is the outside room. Oscilloscope is no overviews is the tumor. By endoscopy, the position is this is dissected tumor, dissected. Situate the muscle layer. Avoid the defect caused by post-operation tissues. No. Case 6. Large leukemia, lateral the esophagus, young man, young female. The CT is significant. This is the biggest is the tumor. Endoscopy is the slight. This is the US. This is the 3D reconstruction. This is the esophagus tumor is closed, and the stomach about is 6.4 and 3.7 centimeter. This is the laparoscopy, and the endoscopy operation is this is the resection the large glandular the leukemia, and prevent is the cardio. Sexual is the muscle is, and avoid the diverticulum. The case is published in the American Journal of Gastroenterology. Recent. Case 7. This is the submucous left lumen. Another is the right leukemia. The reconstruction is the tumor is the biggest. Left is the right is the tumor. In case store is the second gastric the result of is the perforation, because the numerous and esophageal muscle is the repair the pathological examination after gastroscopy showed the bronchial system. The left is the tumor is the soroscopy is the couldn't find tumor. This established tumor is the submucous lymphoma, separated the tumor. Total is finally the specimen is the conclusion is the endoscopy, the treatment of the esophageal SMT is wide cardiac attention. Should be the part of differentiating from the case, especially evaluating the external vessel processes. Conventional CT is the important diagnosis. Additional ability to assist for the need the approval. Solid reconstruction that can be whether reflect over the morphologic characteristics of tumor. This patient at the center relative with the surrounding organs. Small is just the larger vessel. Both the many invasive and the safe endoscopy the resection is the operating room. Post the resection is the expected difficult and the less endoscopy resection under the solicioscopy the survivors. The tumor should internal the glossy. The solicioscopy is the external localization. The resection was difficult. Endoscopy tonal resection that the surgeon location in the resection reduce the risk of the music of the injury and the necessary transect in the blood vessel and improve the safety of the surgeon. Thank you very much.